Are you a high school baseball pitcher that's hurt your arm recently and you're really just not sure what's wrong and how to go about getting the answers to figure out what's injured in your arm? I'm going to go over today the process that I use to determine whether or not there is a UCL injury in pitchers of any level. How do I know this? My name is Dr. Jeff Lewis. I'm the owner and physical therapist of Lewis Physical Therapy and Sports Rehab in Point Pleasant, New Jersey, where I've helped countless baseball players get back to throwing pain-free, get stronger, and throw harder after an injury. Want to go over today the process that I use for identifying and recognizing UCL injuries in pitchers. I see UCL injuries in other, I will say in other fields, athletes as well. More commonly, it's usually either maybe some type of combat sport or some type of very aggressive overhead lifting, like an Olympic lifting where that arm gets out and you maybe get a very quick valgus stress. But more commonly, I see this in baseball players in my practice. So your UCL, that's your primary static stabilizer for your medial elbow, and probably the injury in baseball pitchers that gets the most attention compared to others. One of these things that we want to be mindful of is, especially in an athlete that's, let's say, under the age of 16, we do want to be mindful of the growth plate on the inside of that elbow there. When that growth plate is still open, that growth plate is going to be more vulnerable for injury compared to the UCL. Now, I have seen pitchers younger than 16 that have UCL injuries. It's just one of those things that we want to be mindful of in our younger adolescent pitchers, okay? So first thing we're going off of in anytime a guy comes in our clinic is the history. And I'm just asking them, give me a rundown of what's been going on with your pain. A lot of time, people think that you only hurt your UCL if you have a pitch and you feel one big pop and you have immediate pain. Yes, that happens, but I've also seen the opposite where a pitcher can just have a gradual onset of chronic medial elbow pain that just gets worse and worse and eventually develops into some type of performance deficits and then really the point where they can't throw or pitch at all. I've also seen where it doesn't necessarily mean that there's just pain on the inside part of the elbow. They might have pain that starts on the inside of the elbow, but then it goes to the front, maybe the side, maybe the back. And at that point, that usually just happening because that ligament has failed. So every time they're throwing, stress is being distributed elsewhere and causing an overload in those locations, all right? So history is a big part of that. I'm always going to ask them, have they had any numbness or tingling down to their pinky and ring finger, because that's what the ulnar nerve innervates. Not always do you see ulnar nerve involvement with UCL injuries, but it definitely happens. And if that's a case where a guy has to get UCL reconstruction, such as, in other words, Tommy John, and they have ulnar nerve issues, they might move that nerve as well in that process. They take it from the groove here and just move it directly to the front of that bump on the inside part of the elbow. So history is a big part of it. And then we'll go into palpation. So I'll always start, and I'll start with this. So your UCL goes from essentially the anteroinferior aspect, meaning the front and really the bottom part of that medial epicondyle, which is the bump on the inside part of the elbow, and then it attaches down onto the ulna. Okay, so it runs like along this here. When your elbow is straight and that flexor pronator mass on the front there is tight, you're not really going to be able to palpate that UCL. So really to palpate the UCL in the best way possible, I'm going to have a guy's arm flex so that tissue is put on slack, and then I'm going to almost try to move underneath that flexor pronator mass and move along the length of the elbow there. So I want to see, hey, is it tender when I'm on the insertion on the ulna, mid-substance, or is it, hey, not until I'm on that medial epicondyle where that UCL attaches that they feel it there, okay? If they are complaining of some type of numbness, tingling down to their fingers, I'm going to assess that nerve, that ulnar nerve throughout that track. So I'm going to start really in the lower half of the tricep, where that nerve spits out. And then that nerve runs right in this little gutter behind the back elbow here, okay? So I'm going to track that nerve throughout there, down to the forearm a little bit. I want to see if my palpation, essentially my pressure on that spot, if that elicits any symptoms down to those hands, or if I tap back there, if that elicits any sign. And if it does, then, we want to be aware, there's probably some type of ulnar nerve involvement, okay? Next, we're going to go into elbow range of motion. Most guys will likely feel stiff getting into elbow flexion more than anything. Some might have full extension right away. I've also seen cases where it is really irritated and inflamed. Everything around there just spasms to protect, and they just don't have range of motion with anything, okay? So range of motion is something we want to be mindful of there. Specifically going into elbow extension range of motion, I don't necessarily care about only seeing it in a slow movement. I'll also do what's called the bounce test, and I'll literally take their elbow and I'll just bounce it like that more than anything. The reason I want to do that is I want to see if there's any type of posterior compartment, meaning back of the elbow pathologies involved here, to see if, hey, is there something else going on? Do we have to be worried about any loose body or bone spurs back there? And again, that's not something, if it goes surgery, that I'm going to fix. That's more just something I'm just maybe going to relay to the orthopedist if I'm likely referring them out at that point, okay? So now we're going to go into shoulder range of motion and strength. Now, depending on the severity of this injury, you might not be able to really get a good assessment, but shoulder range of motion is a big predictor of elbow strength, specifically, of elbow injury. So overhead flexion with and without that lat, that scap blocked, horizontal adduction. Ideally, I want to see guys be able to get their elbow to as close to their nose as possible versus being stuck back here with their scap blocked. Internal, external rotation, total range of motion as well. And then I'll take a look at your shoulder strength. So I set up guys on a dynamometer, have them push externally as hard as they can, and then internally as well. Compare that ratio side to side, and then the external internal ratio on the same side as well to see if it's within the values that we want to. Next, we're going to get into wrist, forearm range of motion and strength, especially going into strength here. So your UCL, that's the primary static stabilizer for that medial elbow for pitching. The big dynamic stabilizers, there's two muscles in particular that lay directly on top of that UCL. Your flexor digitorum superficialis and your flexor carpi ulnaris. So those are two muscles I absolutely want to assess in my exam to see, hey, is contraction of those muscles, is there such a big enough injury going on there that just contracting those muscles is bothersome, or are they spastic more than anything, okay? So for the flexor carpi ulnaris, I'm going to have their elbow bent, hand gets dipped down like that, they're pushing up into me here, and then I'm going to have them do it in the straight arm as well. For the other flexor, I'm going to have them go in a claw hand, and I'm going to have them try to hold that position by me pushing at essentially right in that middle, like right between the tip and the bottom of that finger, right above the knuckle there. See if they can hold that there. That's going to be that flexor digitorum superficialis. I'll also just focus on trying to resist at the tip there to get another flexor. But again, those two especially I want to assess the strength of to see if there's any associated weakness or if just the contraction alone of that muscle is bothersome to the elbow, okay? And then we're going to move on to valgus stress testing. So we're going to have that arm straight at 0 degrees, and I'm going to essentially pull their forearm. So if you look at my forearm here, I'm going to apply my stress to their forearm gets pulled this way here while this arm is staying still. So you're going to try to see, hey, when you get this valgus, so opening on the inside here, it's a couple things. One, is it painful? And then two, how much laxity is there? In a low-grade sprain, you might get a little bit. You'll get a little bit of laxity, but you'll have a pretty firm end feel. In pretty significant injuries, that forearm is just going to go. It's just going to keep going and going. And that's where you think, okay, there's probably a pretty significant UCL injury here, okay? So you have that one there. Then you're going to assess the same thing in this 30 degrees here. There's going to be another test where I have someone in a 90-90 position here in that thrower's position, and I'm just pulling their thumb back, so creating that medial stress of that UCL in that position there, and then I'm pulling again and moving their arm out. So we're just assessing the UCL's integrity in a couple different ranges of motion. And if some of those are starting to be bothersome, especially, then I'm really at that point starting to think, all right, there's probably some type of UCL injury going on here. Now, it's important when you do these tests up here, if you ask them, hey, does it hurt? And they're like, yeah, don't just move on. Ask them, okay, hey, where does that hurt? Like, point to me where it hurts. If they point to the shoulder, yes, I'll be mindful of it, but that's not necessarily related to here. If they're like, hey, when you do that, it's pain, bam, right there, can pinpoint it, that's what we want to be concerned about from a UCL standpoint, all right? Functional movement, that's going to be looking at more thoracic spine mobility, hip mobility, single leg squats, lunges, really just how they move in general. And then the last part here, which we're kind of doing as we go along through this, is ruling out. So we want to rule out, is there loose body involvement? Is there some type of potential bone spur maybe? Is there an ulnar nerve involvement? Is there an associated muscular component, like an associated flexor pronator strain with it? A lot of times people get thrown off because, hey, they're really tight along here, so they think, oh, it's a muscle strain or whatnot. Don't think just because someone is tight and it hurts to contract there, don't think that just because that's the case there, that's a muscle strain. That could very well be secondary to the bigger injury at the UCL here. So don't just make sure that it's not thrown off like that. So this is a rough overview of the process that I use to go about examining for a UCL, ulnar collateral ligament injury in pitchers, but any other active individual that could potentially fit in the scenario that there might be a UCL injury. So if you have questions specifically about your elbow pain that you're having with pitching and you're trying to find answers on what it might be or whatnot, go ahead and leave a question below in the comment section or text the number below and we'll get back to you with more direct answers and ways that we can help you personally.